Hello, everyone. Welcome. Welcome. I'll let you get settled in. We're very excited you're here. This is Kate Scarlotta. I'm the VP of Nutrition and Translational Science at Epicure. We have a wonderful webinar scheduled in just a moment. The title is GI-Focused Behavioral Health Services for Patients with IBS, a Practitioner's Guide to the Referral Process, with Dr. Elise Talker. So we'll get started in just about 15 seconds with a brief introduction about Epicure. Okay, next slide, please. Oops. Sorry about that. Let's get started. Here we go. So as an introduction, Epicure is a healthcare company that creates food as medicine. We've paired Michelin star chefs with some of the best doctors and dietitians in the US. Epicure translates medical research into delicious food for patients requiring prescriptive diets. There's many benefits of using Epicure. It can be utilized as diagnostic support, almost leveraged as a diagnostic tool to test for FODMAP sensitivity. By just trying a few days, I would recommend up to 5 to 7 days of elimination phase friendly food. An individual can really assess whether they're FODMAP sensitive or not before in-depth education or even invasive procedures. There's really little stress for the patient, which I really appreciate. The diet can be complicated, as you know, that for those that have applied the low FODMAP diet with patients, and Epicure really takes out the guesswork, making it easy. It's also peace of mind where patients can relax knowing that the food is going to be freshly made, delivered to soothe their digestive symptoms, delivered right to their doorstep. What I really like as a dietitian is the nutritional adequacy that Epicure provides, really utilizing a diet that's Mediterranean with a twist, low FODMAP, plant-forward menu with lots of expansive options, 70 menu items for patients to really enhance their plant and fiber intake into a well-balanced nutritional diet. So as many of you know, our first menu has really focused on digestive health. Everything that Epicure makes is low FODMAP as well as gluten-free, and this serves a variety of digestive conditions from IBS, Crohn's, colitis, and SIBO to celiac and non-celiac gluten sensitivity. The low FODMAP diet can be complicated, but the good news and what I see in practice day in and day out is that it works for many patients. In fact, it's effective in managing symptoms in up to 86% of patients with IBS. So really high quality evidence to support its use as first-line therapy in specific patients with IBS. And Epicure has a number of partners in health that we are proud to work with, including many of you listening tonight, tonight. Many major health systems from Mount Sinai to Michigan Medicine to Beth Israel Lahey Deaconess, to many thought leaders, including Bill Che and Tony Lembo, independent private practices, and patient advocacy groups such as the Crohn's and Colitis Foundation, IFFGD, and the National Celiac Association. So we're in partner with a number of different experts, 2 research studies right now deep, and I'm really happy to move the science forward in an area that is really impacting health outcomes with food. So without further ado, I'd like to just briefly introduce Dr. Elise Talker. She's a GI health psychologist and assistant professor of medicine in the Division of Gastroenterology and Hepatology at Atrium Health in Charlotte, North Carolina, where she recently developed a GI psychology clinic. She also serves as an assistant clinical professor in the Department of Psychiatry and Behavioral Sciences at Baylor College of Medicine. She is involved in clinical care, teaching, and research. As we'll have Elise pull up her slide deck right now. Please use the feature on the lower part of your screen, the chat feature, to submit any questions that you may have, and we'll do a brief question and answer session at the end of Dr. Talker's presentation. Thank you very much, and Dr. Talker, take it away.
Thank you so much for having me. Does my screen look okay?
Well,
let's see.
You just need to share it. Yep.
Share it again. How does that look?
Not yet.
Not yet. Okay, let's try this again. And here we go.
Yep, there you go.
Great. All right, so.
File for the beginning. Yep, there you go.
All right, thank you for having me. I'm really glad to be here with you all tonight. So today I'm going to talk about GI-focused behavioral health services for patients with irritable bowel syndrome, a practitioner's guide to the referral process. I have no disclosures. In this talk, I'll describe how behavioral factors might influence IBS. I'll review IBS-focused psychotherapy interventions, and I'll discuss GI behavioral health referral options for patients with IBS. So what is irritable bowel syndrome? As many of you know, IBS is a significant public health problem impacting a large proportion of adults in the US. And according to the Rome 4 diagnostic criteria, IBS is characterized by abdominal pain associated with altered gut motility. In addition, patients often report other symptoms such as bloating, fatigue, nausea, urgency. And it's important to note that although IBS is historically known as a functional disorder, it's now characterized as a disorder of the gut-brain interaction. So why is psychological treatment important in the management of IBS? Well, we know that IBS is influenced by behavioral factors, and that psychiatric distress is often elevated among patients with IBS, and IBS itself is a stressor. We know that IBS is a chronic condition, and that patients often need multiple approaches for optimal care. So what makes psychological treatment an optimal supportive therapy for IBS? Well, alongside conventional medical and dietary interventions, we know that psychosocial processes can modify the brain-gut interaction, and therefore it would make sense that we should directly target these processes in treatment. And given that IBS is characterized by multiple factors, our treatment approach should probably be well-rounded. Of course, this aligns well with the evidence, such as comparable efficacy between antidepressants and psychotherapy, and that interventions such as hypnotherapy can improve psychological factors as compared to dietary approaches. And lastly, research indicates that behavioral interventions work. They improve IBS symptoms, emotional well-being, and quality of life for this patient population. So what are the evidence-based interventions for patients with IBS? Well, a recent systematic review and meta-analysis indicated that cognitive behavioral therapy, relaxation therapy, multi-component psychological therapy, hypnotherapy, and dynamic psychotherapy have been shown to be more effective than control therapy, with number needed to treat between 4 and 6. And other treatments, such as multi-component psychological therapy delivered via telephone, contingency management, and emotional awareness and expression training, appear to be beneficial, but there was only one randomized controlled trial for each of these. That being said, most people use CBT and gut-directed hypnosis in clinical practice, so I'll focus mostly on those today, but I'll also discuss some of the other approaches. In addition, a later systematic review and network meta-analysis that I was recently involved in confirmed these prior findings, but it was also important to note that CBT was more efficacious when administered in various forms, including via telephone, group, or self-administered or minimal contact therapy, which differed from earlier findings. And other interventions, such as stress management, that previously demonstrated no benefit, were shown to be beneficial in this study. In addition, previous reviews have demonstrated the short and long-term efficacy of psychological therapies for IBS, regardless of delivery method, whether in person or online. But this study demonstrated that CBT via telephone appeared to be the most beneficial long-term. So in the era of COVID-19 and the pandemic we're all experiencing now, we see that technology-based interventions are no longer the wave of the future, but rather the focus of the here and now. So I just wanted to emphasize that this has also been researched, and research has demonstrated that such interventions are also effective. So now let's dive into what GI-focused behavioral interventions entail. Well, the theory of cognitive behavioral therapy is that maladaptive thoughts trigger psychological symptoms and physical tension, which can trigger or exacerbate IBS symptoms and contribute to gut-brain dysregulation. IBS-focused CBT is actually targeting IBS symptoms themselves and not psychological comorbidities, although they may improve as a response to some of these interventions. And the goal of CBT is to help patients develop skills to deal with stressors and GI symptoms more effectively. It's important to emphasize that this intervention is generally short-term, between 4 and 10 sessions, and it's focused on the present. At the beginning, motivational factors and targeted treatment goals are identified early on in therapy and discussed throughout the therapy process. Treatment itself involves psychoeducation, cognitive, and behavioral components. Well, that all sounds good, but often people have no idea what CBT for IBS actually means. So I'm going to describe some of the components in more depth now to give you a better framework. And I really want to note, in addition, that all of these components are not used for every patient, every session. It really depends on their needs and circumstances. And even in therapy, we might pick and choose which components are most beneficial for particular individuals. So first, I'll start off by talking about psychoeducation, about the gut-brain connection and the relationship between stress and IBS. That's almost always a part of psychotherapy because it helps patients develop insight into what might be influencing their symptoms and helps them understand they may be able to control factors such as responses to stress or arousal that may be contributing to their symptoms. Self-monitoring is sometimes used to help patients build awareness about triggers and things that might impact bowel symptoms, such as daily hassles or attitudes, activities, things like that. This helps patients change by helping them get a handle on what can be controlled and gives them a baseline in which they can evaluate their progress. Might also keep them motivated and help them to identify where they can learn new skills for coping. But I also want to note that this may be less helpful for patients who are highly focused on their symptoms because they might be too hypervigilant to gain benefit from that. In addition, relaxation training helps people learn how to reduce arousal and stress, which helps them gain a sense of control. There are several relaxation strategies such as diaphragmatic breathing, progressive muscle relaxation, and guided imagery. Cognitive restructuring is also used, and that's aimed at reducing symptom-related anxiety and hypervigilance. The focus is really on reducing negative thinking patterns and worry related to symptoms. Patients may be asked to track thoughts and learn new, more adaptive ways of thinking. Also, problem solving helps people more flexibly address problems. Patients may be taught active problem-solving strategies for controllable problems and more emotion-focused strategies for uncontrollable problems. Examples of emotion-focused strategies might include reframing, reinterpreting the meaning of a situation, getting support, acceptance, or letting go. And exposure to feared situations helps patients to minimize avoidance and safety behaviors, which which IBS patients often have and present with. I also want to note that addressing health behaviors such as exercise, routine, and sleep may help promote healthy lifestyle habits, and that can also be a very useful strategy for this population. In my own clinical practice, I also include elements of mindfulness with CBT interventions. The next type of treatment that I wanted to describe was gut-directed hypnosis or gut-directed hypnotherapy. And hypnosis targets stress and gut sensitivity by inducing a state of deep relaxation and focused attention that allows people to become more receptive to suggestion, which in turn facilitates healthy changes in the mind and body and re-regulates the connection between the brain and the gut. It's a verbal intervention that involves a script, and many of you might be familiar with Ollie Paulson's scripts for IBS and related conditions, which are very useful in clinical practice. Patients initially receive hypnosis in session and then are taught how to engage with hypnotic techniques on their own to manage their IBS symptoms long term. So the next question is, how do people view hypnosis as a clinical intervention? Because sometimes when you bring it up, patients may be afraid of what that actually means and whether or not they would lose control in the experience. But in a national population-based survey in the US, actually, most people reported a positive or neutral view of hypnosis, and about half were willing to consider hypnosis treatment. And again, most people reported hypnosis as a useful intervention for those who actually went through it. So I think the bottom line is actually people like it. And I also see that observationally in my own clinical experience. Other interventions, such as acceptance and commitment therapy, are newer options for IBS patients. Although there's been limited research for IBS specifically, ACT has been shown to be effective for chronic health conditions generally, and it's considered a transdiagnostic treatment approach that can benefit a lot of different patient populations. It's an action-oriented treatment that stems from traditional CBT, but has a little bit of a different twist. So it uses acceptance and mindfulness strategies alongside commitment and behavior strategies to increase psychological flexibility and engage patients in value-based activities. And as you can see here on this slide, there's been a self-help ACT book that's very useful for patients and providers who choose to go this route. It's up here on the side, and you can purchase it on websites like Amazon. I also want to mention another intervention called emotional awareness and expression training, which I developed with my team during my graduate school program for my dissertation. So what I did is I conducted a randomized controlled trial to develop and test this emotional awareness and expression training intervention to help patients identify, experience, and express emotions related to stressful life experiences and interpersonal relationships. And we compared this conceptually distinct treatment to a traditional intervention relaxation training to see if it would be beneficial as compared to something that is more often used. This study was funded by American Psychological Association, Blue Cross Blue Shield of Michigan, and Wayne State University. We recruited 106 individuals with IBS, primarily female, with an average age of 36. So in this study, both interventions were administered in 3 weekly 50-minute individual sessions. And we looked at IBS symptom severity, quality of life, and psychological symptoms such as anxiety, depressive, and hostility symptoms at pre-treatment, 2 weeks post-treatment, and 10 weeks follow-up. I'm just going to go over some key findings, which is that compared to controls, emotional awareness and expression therapy, but not relaxation training, significantly reduced IBS symptom severity at both follow-up time points. And both interventions significantly improved quality of life at these follow-up time points. But compared to controls, both interventions had significantly lower anxiety only at the 2-week follow-up time point. And interestingly, emotional awareness and expression therapy and controls had a different response to depressive symptoms as compared to relaxation training, which was significantly relaxation training rather, had significantly lower depressive symptoms at that 2-week follow-up time point. Hostility was not significant. So really what the conclusions are here is that emotional awareness and expression therapy that targets trauma and emotional conflicts reduce somatic symptoms and improve quality of life in patients with IBS. So the big takeaway is that this emotion-focused approach may be considered an additional treatment option for this patient population. And in my own clinical practice, I do like to incorporate it for patients with relational difficulties because it really adds that extra element that maybe some of the interventions may not be able to address. So now the question becomes, well, now what? What's happening with IBS treatment in the real world? Is it this, that physicians are saying to patients, I'm afraid your irritable bowel syndrome has progressed. You now have furious and vindictive bowel syndrome. Well, not exactly. In a recent systematic review, we found that psychological treatment for IBS delivered in GI clinic settings can reduce IBS and psychological symptoms and improve quality of life. But how often are patients with IBS referred to behavioral medicine? And the answer is not as much as we'd like. In the HMO setting in Seattle, only 10% of patients with IBS were offered a referral to a mental health provider by gastroenterologists, and only 9% by primary care physicians. And referral rates from other integrated care settings, such as VA and non-VA academic medical centers, are unreported. So during my fellowship, I worked with a team of colleagues to develop a referral toolkit for gastroenterology providers to identify the best candidates for behavioral medicine services and provide guidance for the referral process. And this may help change and reduce some of those gaps in care. So GI providers and other providers may be able to more easily refer patients to needed services. This study was funded by the South Central MIREC and was also conducted at a VA and non-VA setting, Baylor College of Medicine and the Houston VA. The first aim of the project was to better understand stakeholder perceptions of barriers to the adoption and implementation of behavioral treatments for patients with IBS in VA and non-VA clinic settings. To do so, we conducted a qualitative formative evaluation using in-depth interviews with patients and providers. We also had clinical leaders offer additional perspectives regarding the importance, feasibility, and acceptability of behavioral medicine and the toolkit approach. Interview topics range from attitudes towards behavioral medicine, identifying who is appropriate for treatment, understanding attitudes towards referral processes, and how patients and providers can communicate about IBS symptoms and treatment most effectively, and understanding barriers and facilitators to treatment attendance. The second aim of this project was that information gathered from the in-depth interviews was used to develop the referral toolkit itself. And we used rapid qualitative analysis to identify preliminary themes which informed the development of the referral toolkit. And feedback obtained from patients, providers, and clinical leaders guided modifications to toolkit materials. And just to give you a sense of how many individuals we recruited, we found that across the VA and the academic medical center, we were able to get pretty similar numbers. So GI providers, we got 5 gastroenterologists and mid-level providers at the VA and 9 in an academic medical center. Behavioral health providers, we were able to recruit 9 at the VA and fewer in the academic medical setting. And we were able to recruit 12 patients with IBS, both at the VA and at the academic medical center. I'm not going to be able to go through all of the findings. I'm just going to only hit the highlights before I present the actual toolkit to give you a sense of some of the data that helped us create and design the toolkit itself. So we found that patients were willing to try behavioral medicine treatments, but barriers included schedule and location, and timing, travel distance, cost, and transportation. Additional themes that guided toolkit organization included that medical providers were interested in learning about behavioral medicine interventions and they desire decision support tools to help identify candidates. Providers across sites also suggested that it was important to educate patients about IBS-focused behavioral medicine treatments, and patients indicated that they had questions for providers about triggers for IBS as well as treatment options. Providers also suggested that the referral process should include a face-to-face introduction, patient to behavioral medicine specialist, and a consult. And providers agreed that the electronic health record should be central to monitoring and tracking referrals. So now I'll share what this toolkit actually looks like, and you can also download it at the link listed at the bottom of this page. We organize this toolkit in a stepwise approach to help providers determine the best next steps for care. So you can see that here. I'm not going to go through each step, but that's how the toolkit itself is organized. So the first section of the first step is answering the question, is the patient a good candidate for behavioral medicine? While considering good candidates, patients should have at least some of the qualities listed below. So more severe IBS symptoms, so patients should have stress or psychosocial or emotional factors that might be influencing their IBS experience. There should be some level of motivation or interest in behavioral health care. And it's also really important to pay attention to if the patient believes that they can control or learn ways to control their IBS symptoms. I've also listed some key questions a provider might ask patients to help make some of these determinations. I won't go through each of those now, but you can see them listed here. In addition, poor candidates may be those with unstable medical conditions or psychiatric comorbidity that needs to be prioritized. For example, if a patient comes in with severe depression, they might not be able to engage in IBS-focused care. So in that patient it may be more helpful for that patient to go to a behavioral medicine provider who can address the depressive symptoms first before they come back and focus on the GI-specific issues. The next step is to educate patients about behavioral medicine treatments. And so education might involve letting patients know that IBS can be worsened by psychosocial factors, educating patient about the brain-gut connection and the stress-IBS link, validating that IBS is real, describing treatment options, and of course, sharing the evidence. One thing that providers might emphasize is that stress impacts the functioning of the gut. So they might say something like, some patients are gut responders to stress. This doesn't mean that your symptoms are all in your head, but they may be related to the connection between your brain and your gut. And that way patients can really understand the treatment targets and figure out if it's an appropriate intervention for them. In addition, it's also important to explore patients' preferences. So identify patients' goals, what their desires are, empower patients, maybe saying something like, it's easy to feel lost when dealing with multiple providers, prescriptions, and approaches to IBS care, but how you proceed with treatment, it's in your hands. The good news is that you can develop new ways to manage your IBS and gain better control over your symptoms with the strategies we talked about today, as one example. Of course, offer the option of behavioral medicine services in addition to other treatment options, and then identify if the patient is interested, proceed accordingly. Now, if the patient is unsure, they're not really sure if it's right for them, you might use some motivational interviewing approaches, such as asking open-ended questions, empathizing with where they're at, maybe reframing and validating their statements, reflectively listening to what they have to say, summarizing their statements, and building their self-efficacy. You could ask something like, how confident are you that you could get better? If they say no, you could say, well, this is a perfect place to start, building your confidence to manage your IBS starting here. Again, ultimately, it is the patient's decision as to how they want to move forward. And if they're not interested, you might start by exploring why, but of course not pushing them if they don't want to do it. There are other ways to manage symptoms, as you all are familiar with. The next step is to actually initiate the referral. And this could look different in different places, but the thing I really want to highlight is that behavioral medicine providers could be located in medical settings or in private practice settings. I did list some resources here to see if you're interested in referring patients, you can see if you can find a provider in your area. Or now that telehealth is really becoming at the forefront of care, you might also consider if there's a provider in your state who can provide services, or someone who's licensed to provide services to where the patient is located. After that, it's helpful to engage the patient. So providing the patient with information about how to schedule an appointment with the particular provider that you're referring to, and maybe answering any questions that they have. I have developed an information pamphlet. On the next page, I'll show that, which may answer some questions patients could have. So here, we'll look through that now. I'm not going to be able to read the whole thing, but it is within the toolkit, and I just want to emphasize it talks about what IBS is, potential causes, how IBS and stress are connected, specifically getting at some of those behavioral or psychological factors that could be playing a role. Why seek help? It helps patients kind of reflect on that. And it also talks about how IBS is treated. In addition, we do talk about how can a behavioral medicine provider help you. So it gives patients an understanding of that. And it gives a little bit of information about potentially what the time commitment might be. And on the bottom there, we talk about some of the most common treatments. In addition, resources are listed here that may be useful for providers as well as patients, and including IFFGD, where there's lots of resources for patients, as well as educational materials providers may give patients. University of North Carolina Center for Functional GI and Motility Disorders also has a lot of patient education materials, in addition to GastroGirl. If you're looking for information about hypnosis specifically, you could go to Dr. Ollie Paulson's website. Great information there, and also a list of providers who do provide hypnosis. In addition, the Rome group has a GI psychology section, and it does list providers throughout the country. So if you're looking for GI psychology trained providers, you could go there as well. In addition, I have listed 2 books that are very useful for patients, as well as for providers who are interested in learning more about these approaches. For CBT specifically, Dr. Jeffrey Lackner has developed a book called Controlling IBS the Drug-Free Way, a great resource, and as well as Dr. Emrin Meyer, who is an excellent book on the mind-gut connection. So for the toolkit, I just want to acknowledge the following individuals for their contributions and support: Lori Kiefer, Brian Lacey, Walter Smalley, Ashley Helm, Lindsay Martin, Tracy Smith, Mindy Stanley, and Sonora Hudson. And of course, we also thank the several patients and providers who gave their input on this project. So now considering future directions, what's next for me and those of my colleagues. So I've recently developed a GI-focused behavioral health service in the gastroenterology and hepatology division at Atrium Health in Charlotte, North Carolina, with an absolutely wonderful team. And we're moving forward to continue to develop our clinical service or research program, collaborate across fields, and seek new ways we can continue to improve patient care in the best way possible. So, the future is bright. I know we're all kind of living in this pandemic, and there are hard days, but we have to remember with hard days come opportunity as well. So thank you for your time. I really enjoyed speaking here tonight, and I'm going to open up the floor for questions and comments, and I'd love to have a discussion.
Love it. Thank you so much, Dr. Tucker. It was really, it's always, we've had a number of GI psychologists present to our clinical audience, and everyone has just some overlap, obviously, but really looking at ways to select patients. I really appreciated who is a good candidate for behavioral health versus maybe individuals that may be less of a good candidate. That was a really important slide. Let's see if we have any questions. I'm not sure that we do. So what I'd like to do is, we do, wait a second, I think. So we do have a question. This is, what are your thoughts regarding rectal hypersensitivity and GI psychotherapy? So would
Sure.
GI psychotherapy help with rectal hypersensitivity
Yeah,
specifically?
I think it's really important to consider the full spectrum of issues that patients with IBS and related conditions might have. And I absolutely think that GI-focused interventions can influence rectal hypersensitivity. We know that patients with IBS and related conditions often are influenced by stress, and psychosocial factors in their life that might be stress-inducing, or when we think about the disorder itself as a stressor, that can be contributing to some of that hypersensitivity. And so if we think about staying as relaxed as possible, reducing arousal, reducing stress, I do think that that could certainly influence rectal hypersensitivity. So relaxation strategies, cognitive restructuring, if that, thoughts can be a source of distress, can certainly influence clinical outcomes.
Excellent. And can you just expand a little bit on acceptance commitment therapy a little bit? Like maybe provide an example, just so I understand the concept a little bit. I know it's very interesting to me, and I still don't have my arms around it fully. And I'm sure there's some clinicians listening in that might benefit from understanding that a little bit better.
Sure. I would say one of the biggest differences between acceptance and commitment therapy and traditional CBT is that acceptance and commitment therapy is not focused on reducing symptoms. It's focused on enhancing psychological flexibility and helping patients engage with value-based activities. So living life more consistently with their values. And so that's why it's more of a transdiagnostic treatment approach, is that we're not specifically targeting symptoms. It's more about helping patients function more effectively in their life. Does that help?
That totally does. And, I'm reading as part of some education, a book that, kind of highlighted some of those values. And I'm wondering, do you happen to know some of those like values specifically? Like I can remember in the book, it called out like one of the ones that resonated with me was adventure and gratitude and different values. Like, so I'm just trying to give an example how you might work with a client specifically with certain values. Like,
Sure. A lot of my patients who come in and we're doing ACT-based treatments, we might focus on, valued interpersonal relationships, or patients who value focusing on their career. And a lot of times people are focused on their health, things like that, different aspects of their life. But, you mentioned some other values like gratitude and I think those are important to incorporate too. And I often do incorporate a lot of that with patients. I think the mindfulness component of ACT is really, really helpful for people, like living in the moment rather than being caught up in the past or the future, especially for those more anxious patients.
exactly.
So I do think understanding your values is an important first step, and then living in accordance with them, really committing
Exactly.
to act in that
I think
way.
we all need a little refresher sometimes, like really to identify, because I do think those values obviously change a little bit throughout life, and reevaluate them and make sure that, you're really in tune to them and that you're embracing them. So I'm very intrigued by that. What about mindful eating? Is that something that you work with patients at all?
All the time. Yep, I'll incorporate that, both with ACT and CBT, depending on, what patient I'm working with and the focus. But, I can think of 3 or 4 patients within the last few weeks where I just focus on mindful eating, because oftentimes patients are rushed, and the digestive system really likes routine. And the more rushed and stressed you are, the harder it is for you to digest, right? So we focus a lot on really sitting in an environment that's calming, not stimulating, maybe incorporating some diaphragmatic breathing in that process, and really being present with the food, noticing it with your 5 senses.
I love that. And we do have another question. What can dietitians do to learn some techniques to use with our patients, not to step over the role of a GI psychologist, but just, I know, like, I have an answer that I think I would throw out to you, but I'm going to just let you answer it. You know, what do you think as a dietitian or a GI doctor? Is there something that we could recommend maybe with a patient that isn't, you know, severely compromised and feel like is ready to see the GI psychologist right today, but maybe we could try something? Is there anything that you would recommend?
Yeah, I mean, I think you could start with diaphragmatic breathing and some of those stress management approaches that we might just do 1 or 2 sessions, for with patients. Sometimes patients can easily get videos or links to help them do self-management. There's been research where patients can engage in these things on their own or with limited guidance. And so I do think starting small with some of those easy interventions like diaphragmatic breathing, like I mentioned, or even mindfulness as a way to get patients on board. And if they do feel like they'd like more support or additional guidance or care, then sending them to the GI psychologist could be a good next step.
Yep, exactly what I was thinking the same. I think the diaphragmatic breathing is something I know most of our clinicians that listen are registered dietitians. And Dr. Megan Reel has a YouTube video really showcasing simply how to engage in diaphragmatic breathing. So that's a resource that you could look up easily. Any other resources specific to diaphragmatic breathing that you would want to call out?
I would say that is definitely one of my go-to resources.
Okay.
I also really like the 5 senses mindfulness exercise. And if you Google that, it's really just teaching patients to engage in mindfulness using their 5 senses. It's a really brief strategy, so you can add that in addition to diaphragmatic breathing. There's lots of different websites that talk about that, but it's really just helping patients use their senses to bring them back into the moment and ground them in the moment.
I love that. And another question is, what are your thoughts regarding RFID and maybe just like a brief introduction about RFID and emotional therapy used in the Wayne State University project? Is that is that therapy appropriate for RFID? And maybe just a brief introduction of RFID if you'd like to, and then.
So yeah, RFID's a little bit different. Patients with RFID might have significant weight loss and maybe a fear of food, just to simply discuss it. And it's a little bit separate from what I might do for patients with the emotional awareness and expression training. So RFID might have more behavioral strategies may be appropriate for RFID, whereas emotional awareness and expression therapy may be more appropriate for patients who have relational difficulties, maybe a history of trauma or other relational difficulties that may not have been traumatic, but significant, unresolved stressors, things like that. So I know those are 2 very separate kind of concerns that you would want to address within patient care.
I love that. So just as a refresher, avoidant restrictive food intake disorder, also known as RFID, is a type of feeding or disordered eating where individuals are less concerned, such as in traditional eating disorders, with their weight, but more of the fear of consequences of eating. And so in the GI population, we may see RFID, and there is some data to see that it seems to be of concern because many GI patients are food triggers symptoms. So the development of fears associated with eating can occur. In RFID, there's consequences. So they may be more like they're losing weight, they're not meeting their needs, they may need a tube feeding and that sort of thing. So just again, we did get another question. RFID stands for Avoidant Restrictive Food Intake Disorder, and this is a fairly new diagnosis on the DMS-5 that is related to a decline in eating due to fear of the consequence of eating, choking, GI symptoms, that kind of thing. And we don't have a tool to diagnose RFID that's validated in individuals with GI conditions, but they have used the traditional, there's a screening tool, a 9-item screening tool that they have used in GI populations. And using that tool, it appears that individuals with GI conditions are at greater risk for meeting the criteria for RFID. And so we just want to be careful as dietitians, if our patients have extreme food fears, that we're not putting them on further restrictive diets or feeding into that food fear relationship. We really want to make sure that we're helping them not feel fearful of eating, and make sure that we're not over restricting their diet for sure. I don't believe, but I'll double check that we have any further questions. So let me just see if I have a couple, and because I did write down a few, and I just want to see. Can you just talk a little bit about psychological flexibility?
Sure. So that's really the goal or aim of acceptance and commitment therapy. And so what we're hoping to achieve is help patients, those patients who are kind of stuck in their kind of narrow ways of living and thinking. We want to expand their world so that they can engage more readily in their life and in activities that they value and with people that they value. So psychological flexibility helps patients expand their thought and processes as well as their actions to become broader in their world as opposed to very, very narrow in their thinking. Does that make sense?
Totally. Yeah. And I think, when I think of from a dietitian, I always say, the goal of modifying your diet is not so that you're living at home and not dining out. It's trying to find that fine balance of helping control or modify your symptoms so that you can dine out, or find some happy medium of expanding your life, not bringing it in to a more restrictive space.
Absolutely.
I think we've finished up a little bit early. So any final thoughts or questions, and I'll put that out to the individuals that are listening. We have an engaged group because no one seems to be leaving, so I love it. Is there any other final thoughts that you wanted to put out to this clinical audience?
Yeah, I think what I want to emphasize is that every patient is unique, and that even though there are evidence-based interventions that have been demonstrated to work, we also have to understand that the patient comes from their own unique background, and incorporating what works for that patient is really important. So meeting the patient where they're at. And so, when I refer to dietitians or other types of providers, I always want to make sure that, we also coordinate care. So talking to the dietitian and letting them know where the patient is at from a behavioral standpoint, and I like to hear about where the patient is at from a dietary standpoint or a medical standpoint. So I think it's great to have a team-based approach.
Yes, and I think the research really looking at this multidisciplinary approach in IBS and functional gut disorders is starting to gain some traction and interest. I've always believed that when we work together as a team, the patient really does feel supported. And IBS, is really a complicated diagnosis, and couldn't agree more about the individualized approach. We definitely try to be that way from a nutritional standpoint as well. But meeting the patient where they are, and that is, important, and the whole patient shared decision making. If a patient's not interested in nutrition, then, I'm not going to be much help to them. So, and I think the other thing with the psychological and behavioral therapies is that there's a little stigma, and I don't think patients often understand the gut-brain axis in this dysregulation. And once you explain it to them, they're so much more open to trying different therapies. So I think, as clinicians, we need to engage on these topics in a way that, if you just say, well, you need to see the GI psychologist without any preface, or psychologist is, I think it's about your delivery and how we're referring people. I remember
Sure.
as a dietitian years ago, in a practice, the patient would be told, you know, try to go on a low cholesterol diet and see what you can do. And if they failed that, it was like, well, I guess you have to go to the dietitian. Like it was,
Mhm.
you know, a negative. And I'm like, please don't
Mhm.
address it that way. It's positive, you know? So I do think sometimes the way we discuss these topics, and that it's not that you failed it on your own, but rather you have a lot of resources to help manage your symptoms. And a GI psychologist is one option, and a dietitian is one, and the GI doctor is one. And often they can work beautifully together to
Mhm.
support you, right?
Yeah, I absolutely agree with that. And it's one thing to see research about it; it's another thing to see it in clinical practice. And I think I think it's really true. So it's great that the research is translating to real world settings, right? And so, and I would also add that patients really do well when they feel heard and validated. And so I really like that you emphasize patient-centered care. I think that's absolutely fantastic, and it's a great thing to remember when you're talking with patients and engaging them. And I think patients do best when they come to see me when they've already understood that we're kind of all on the same page.
Absolutely. Yep. Couldn't agree more. And it's really nice to see various departments in GI really expanding into a multi-centered practice. You
Yeah,
know, really
absolutely.
seeing GI psychologists popping up, GI dietitians being incorporated into practices. Um, you know, and I know that's definitely part of Atrium Health model. So,
Mhm.
you know, it's awesome. So with that, I guess we get to end our discussion a little bit early. For those of you that are looking for your credits, we will be forwarding an email over the next day or two so that you'll get your credit from CDR. And of course, if you have any questions at all for our clinical team, please reach out at clinical@getepcured.com. If you're interested in other topics for webinars, we're very open to that. And again, we really appreciate your time this evening for a really wonderful presentation again to Dr. Elise Tucker, and for all of you for listening in. We appreciate you joining us this evening. So have a wonderful evening, and we'll be in touch.
All right. Thank you so much, everybody.
Bye.